Wonderful. Thank you so much, Dr. Bejar, for that fantastic summary of how the mutational profiles are helping us with diagnosis and differentiating between different myeloid disorders. So we're hoping that the next step is we are going to repeat the panel and see if you guys were paying attention and learned from Dr. Bejar's excellent talk. So again, his panel, which patient is most likely to have MDS? A 62-year-old female with severe thrombocytopenia and a small DNMT3A mutation, a 73-year-old male with a hemoglobin of 9.2 grams per deciliter and an SF3B1 mutation, a 69-year-old male with anemia, elevated white count and absolute monocyte count, and TET2 and SRSF2 mutations, or a 49-year-old female with pancytopenia, mutations in IDH2, DNMT3A, and NPM1. And you'll see the answer to this poll afterwards appear in the chat so that you guys can check if your answer is correct. And again, these are for CME credit, so thank you for filling these polls out. All right, wonderful, great job. All right, so let's get to the questions and answers. We have questions already coming in for you, Dr. Bejar. Dr. Ziba Singh asks, what is the general cutoff for the variant allele frequency for specificity of a clone, and does that vary by gene?
That's a great question, and I'll tell you that different labs have different cutoffs for what they're willing to call. Some labs will call mutations that are present at only 5% or more. But in the paper that gave us some guidance about how to interpret CHIP, they argued that a mutation needs to be present at 2% or greater. That's about the threshold for detection of many of these lesions. But you're right, it does vary by gene. I would argue that there are certain mutations that are present, even in a small amount, could have implications for a patient down the road. I'm thinking of mutations in things like JAK2, which are associated with myeloproliferative neoplasms. If they're present in small numbers, those patients may have a much greater likelihood of developing that disorder. Now, for MDS specifically, that study that I described from Luca Malcavati, they used a 10% cutoff. So mutations that were present above 10% were used to define clonal cytopenias by determined significance. And I would argue that anything below that runs the risk of being confused with CHIP. So the greater the VAF, the greater the likelihood, but you can't necessarily ignore those low VAF mutations.
Thank you for that. And Dr. Allele Carson asks, what is a broad MDS panel for MDS diagnosis? What are the minimum number of genes you think are necessary to be tested in an MDS patient, a potential MDS patient?
That's another good question, and it's an evolving question. It's one that we're learning more about over time. I would say that different centers do different things. Our center, for example, has a very broad gene list that includes hundreds of genes, including genes that are present in lymphoid and myeloid malignancies as a single test. But the bare minimum is substantially smaller than that. If you look at the top 20 most frequently mutated genes, you're already getting into genes that are mutated in fewer than 5% of cases. I would argue that somewhere between 20 and 40 is going to be the right number that is likely to find those somatic mutations if a patient has MDS, and would be reassuring if the panel gave no mutations whatsoever, suggesting that the patient is less likely to have a clonal disorder. Now, in that paper by Luca Malcavati, they actually did a sensitivity analysis where they took their 40 gene panel and said, what if we limited it to the top 10 most frequent genes? And even that was very, very informative. So I would say somewhere in that range of 10 to 40 is probably the right number if you rank the genes by order of frequency in MDS.
Okay, great. Dr. Bipin Amin asks, with so much complexity, who should actually make the diagnosis of MDS, the clinician or the pathologist?
I still think the clinician has the key role here. The pathologist is extremely critical to this process, of course, and I think they can be very helpful in aiding in that interpretation of both the mutations and cytogenetic abnormalities and the morphologic findings, but ultimately that clinical context really matters. And we're going to need to integrate all that together. I don't think we can defer that responsibility to the pathologist alone. We really need to work in concert with them.
Great. And maybe a follow-up to that, let's say you have a patient with CCUS that has a mutational profile that predicts a prognosis similar to MDS, like in Dr. Malcavati's paper. How would you manage that patient? Would you, especially if they're a transplant candidate?
That's a great question, and a problem that we encounter not infrequently. Fortunately, most people who fall short of the diagnostic criteria of MDS, they don't have excess blasts, they don't have many abnormal chromosomal features. Those patients tend to resemble lower risk MDS. So many of them don't need treatment necessarily. They might need close surveillance, and I would surveil them just like I would a lower risk MDS patient who doesn't need treatment at this time. But there are exceptions to that. There are patients who have either very profound cytopenias, transfusion dependent, and so on, who don't get a diagnosis of MDS from a bone marrow biopsy, but do have these mutations that are typical of MDS. And often we will treat them presumptively as if they had MDS, trying to support their red blood cells with growth factors, et cetera. And in rare cases, even take them to treatment with hypomethylating agents if they do have some of these higher risk features, absent a frank diagnosis of MDS.
Great.
Jane, I have a question for Raf.
Yeah.
Okay.
Yeah, great.
When do you consider the use of a gene panel for germline mutations?
That's a question that is very well answered by your co-host here, but I would say that there are certain scenarios where one needs to be very suspicious of a germline disorder, and that can be a patient who's much younger than the expected age for MDS, but we're learning now that there are certain mutations that are predisposed to MDS that can occur in people who are the typical age for spontaneous MDS. So I suspect that when I see a mutation in one of these genes that can be mutated in congenital cases, even if they might be mutated in somatic cases in other situations, those are genes like DDX41, genes like RUNX1, even mutations in TP53 can be congenital. So you need to look at the history of the patient. Do they have other disorders or morphologic features that are consistent with one of these disorders? Do they have a family history? And importantly, do they have two mutations in these genes that can be present in the germline? For example, two DDX41 mutations or two RUNX1 mutations. And in those patients, I have a greater suspicion that they might have a germline disorder, and we'll need to send dedicated germline testing that is really not something that you can replace by doing a somatic mutation test.
Great. We have time for one more question. So Dr. Buckstein asks, do you repeat NGS serially during an MDS patient's disease trajectory?
That's a good question. I do actually do that. I don't do it on a regular basis. I do it when there's been a significant change in the clinical profile of the patient. So the mutation testing is helpful at diagnosis, in part because it helps you make the diagnosis, but its greater utility is determining what the patient's prognosis is likely to be. And in rare cases, we can actually identify lesions that are targetable by certain drugs. Now, if a patient's disease evolves over time and the clinical features change, I sometimes will repeat the study first to give me a sense of whether there has been clonal evolution, which I think is an adverse finding, but whether there has been the introduction of mutations that dramatically change the prognosis, or perhaps give me an opportunity to use a drug that targets one of these mutations. So I would say that that is something we're doing now on a more regular basis.
Okay, fantastic. So that's all the time we have for your session. Thank you so much for this wonderful, lively interaction. We have over 400 people online today. So thank you everybody for submitting your questions, and we hope this continues with the next talk. So now we're going to continue on. Thanks, Dr. Bejar. So we're going to continue on. Next up, we will have Dr. Amy DeZern, who will be talking about managing MDS in the wake of a global pandemic. And first we have her poll. So her poll will come up in just a second. Everybody get ready to enter your answers as the pre-poll. So her question, to what degree can transfusion thresholds be altered in anemic patients with MDS safely during the pandemic? Select one of the following. Transfusions cannot be safely altered. Increase to a hemoglobin trigger to 10 grams as red blood cells are protective. Decrease the transfusion trigger to 8 grams per deciliter. Decrease the transfusion trigger to 7.5 grams per deciliter. Or last, decrease the transfusion trigger to 7 grams per deciliter. All right, fantastic. So now we'll be listening to Dr. Amy DeZern's talk, and afterwards we'll again have a session of live questions and answers. So please submit your questions throughout the talk. Thank you.